The bottle is the same. The molecule is the same. The patient at the counter is the same. The price is not. One figure is the list price a manufacturer posts to the market. Another is what a pharmacy is paid to dispense the tablet. A third is what a health plan is billed for that same fill on the same day under a contract the patient never reads. Between those numbers sit firms most Americans cannot name: pharmacy benefit managers. Health plans hire them to control prescription spending, process claims, assemble pharmacy networks, bargain with drug makers, nudge utilization toward cheaper therapies. That is the public assignment. Then a second ledger appears. A rebate can swell when a list price swells. A spread can open when a pharmacy is reimbursed less than a plan is charged. A related pharmacy can fill the script that a related benefit manager helped rank on a formulary. The intermediary retained to discipline cost can also earn from the gaps that cost creates. In 2023, Federal Trade Commission staff reported that the 6 largest United States pharmacy benefit managers handled more than 90% of prescriptions. Not a specialty niche, prescriptions.
The ordinary bottles leaving counters, mail-order warehouses, and outpatient windows. This is not an accusation that every contract inflates every copay. The Commission's interim staff report speaks in qualified language about incentives and potential effects. A Government Accountability Office study, written from a different mandate, independently records the same machinery. These firms administer drug benefits, negotiate rebates, and affect drug pricing and pharmacy reimbursement. The paradox is colder than a villain. A payment chain built to manage cost can reward opacity. Millions of people receive the medicine a formulary allows at the pharmacy a network steers, while the bill is carved among manufacturer, insurer, dispenser, and a handful of intermediaries standing in every doorway. Why do health plans keep hiring them? And what exactly are they being paid to do?
Pharmacy benefit managers did not begin as stewards of national drug policy. They began as paperwork. In the late 1960s and 1970s, employers and insurers, drowning in paper claims, hired processors to adjudicate prescriptions the way other vendors adjudicated dental bills. The early firms sat downstream of the clinical decision. A doctor wrote, a pharmacist filled, a claims shop paid or denied. Scale arrived with managed care. As health plans in the 1980s and 1990s tried to bind medical spending, the drug benefit stopped looking like a simple reimbursement pipe and started looking like a design problem. Which products would be preferred? Which pharmacies would be in network? What would a member pay at the counter if a brand had a generic sitting one shelf over? The processor became a designer of rules. Rebates completed the mutation. Brand manufacturers, facing a thickening wall of competitors after patent law and generic entry reshaped the 1980s, learned to pay for access. Access meant formulary placement, a preferred tier, a lighter prior authorization, a copay that did not send the patient walking out.
The payment was not a public discount posted on a warehouse door. It was a private concession, often calculated as a percentage of list price, paid after the fact in exchange for movement of market share. The benefit manager sat at the only desk that could promise that movement. Medicare Part D, launched in 2006 after the 2003 modernization statute, multiplied the stakes. A federal outpatient drug benefit routed through private plans pulled tens of millions of older Americans into formulary wars that had previously belonged to large employers. The same intermediaries who had learned to bargain for commercial groups now bargained inside a public program whose premiums, coverage gaps, and catastrophic thresholds were political facts. States, watching Medicaid drug bills climb, hired them too, or watched managed care contractors hire them. What most patients still miss is not a secret room, it is a sequence. A manufacturer sets a list price. A plan, or the employer behind the plan, delegates the drug benefit. The benefit manager builds a formulary and a pharmacy network. The pharmacy buys inventory, dispenses, and submits a claim.
Money then moves on several clocks. The member may pay a copay or coinsurance at the register, sometimes calculated from a price that has not yet been reduced by any later concession. The plan is billed according to its contract. The pharmacy is paid according to another contract. Weeks or months later, a rebate may travel from the manufacturer to the benefit manager, and some, all, or an agreed share of that rebate may be passed to the plan.
The Government Accountability Office, examining how selected states regulate the sector, treats this not as folklore, but as administration. These companies run the benefit, bargain for rebates, influence what drugs cost in practice, and reimburse pharmacies under arrangements that can include spread pricing, in which the amount billed to a payer and the amount sent to a pharmacy are not the same number. By the late 2010s, states were no longer arguing about whether the intermediary existed. They were arguing about whether they could see the contracts.
Disclosure statutes, spread pricing limits in Medicaid, fiduciary language, gag clause bans that stopped pharmacies from being barred from telling patients a cash price was lower than a copay. The legislative pile grew because the payment chain had become unreadable from any single chair. The contradiction from the counter returns here, with dates attached. The claims desk was hired to make drug benefits cheaper to operate. It became the gate that decides which molecule is easy to obtain, which store may fill it, and which price appears on which invoice. The gate is now so large that a handful of operators stand on almost every path a prescription can take. That concentration is not a metaphor. It is the industrial fact the next act has to name without turning it into a cartoon of a single throat being clutched.
Follow the incentive, not the biography. On one side of the table sit drug makers. Their branded products live and die by access. A preferred tier can mean a therapy becomes the default. A non-preferred tier can mean a prior authorization, a step edit, a higher counter price, and a lost script. Paying a concession to the firm that writes those rules is, for a manufacturer, not sentiment. It is a bid for volume. On another side sit plan sponsors, insurers, large employers, union funds, and public programs. They hired the benefit manager to keep the drug line from detonating the rest of the medical budget. They want a number they can put in a renewal. They also want enough preferred brands that members do not revolt. Those two wishes do not always point at the same molecule. Pharmacies occupy a third chair, and they do not occupy it equally. An independent store buys drugs, waits on reimbursements, and lives on the difference between acquisition cost and what the network allows. A mail-order facility owned by the same corporate family as the benefit manager lives on a different clock.
Specialty pharmacies, which handle high-price therapies for cancer, autoimmune disease, and rare conditions, sit on still another margin because a single fill can dwarf a month of blood pressure scripts. When the benefit manager also owns or is owned alongside a mail-order counter and a specialty counter, the network design stops being a neutral map. It becomes a set of doors, some wider than others. Three corporate stacks dominate the modern picture, not because a statute named them kings, but because insurance, benefit management, and dispensing fused. One stack pairs a retail giant and a major insurer with a benefit manager. Another pairs a national carrier with a long-standing claims giant. A third grows the drug benefit inside a company already famous for medical insurance and clinic adjacency. Smaller benefit managers survive by promising employers a cleaner pass-through or a narrower spread. They do not erase the gravity of the large stacks. Each faction reads the same claim differently. The manufacturer reads share. The plan sponsor reads trend. The independent pharmacist reads whether this fill covers the technician and the rent.
The affiliated pharmacy reads whether the script stayed inside the family. The patient reads a copay and a denial code. None of those readings is irrational. That is the discomfort. A life or death decision here is often not a boardroom speech. It is a formulary committee vote that prefers one hepatitis or diabetes or immunology product because the concession was larger, even if a rival molecule might have been cheaper after a different deal. It is a network update that makes a local pharmacy out of network for a specialty drug that must now travel by mail. It is a reimbursement cut that a small store absorbs until it cannot. Ambition in this market is not theatrical, it is contractual. Whoever writes the terms that sit between list price and take-home bottle writes the industry.
July 2024. The Federal Trade Commission releases an interim staff report on prescription drug middlemen. Staff, not a final commission adjudication. Analysis, not a criminal charging document. The language matters because the temptation is to sand it into a simpler blade. The staff document records concentration so extreme that 6 firms handled more than 9 in 10 prescriptions in the prior year. It traces vertical integration through insurers and pharmacies. It describes formulary influence and effects on pharmacies. It talks about incentives and potential harm in the careful grammar of an agency that knows courts and comments will follow. Read that grammar twice. Potential is not proven in every contract. Staff is not the full commission speaking in a unanimous lyric. A finding about structure is not a finding that your particular fill was padded. Hold that line. The same month, and in the months around it, the older tension does not wait for Washington. Plan sponsors still need someone to police a benefit that now includes drugs whose list prices look like down payments on cars.
Manufacturers still need preferred placement, or they lose the only volume that justifies the launch campaign. Independent pharmacies still open claims and discover reimbursements below acquisition cost on some generics, then make it back, if they make it back, on other fills. Affiliated pharmacies still receive the specialty referrals that network rules make easy. Now, the mechanisms, one at a time, without romance. Rebate negotiation first. A benefit manager aggregates lives. Lives are leverage. The manager offers a manufacturer a place on the preferred side of a formulary in exchange for a concession, often expressed as a percentage off list. If list prices rise and the percentage holds, the concession in dollars can rise too. A plan that is credited with that concession may show a lower net cost, even while the number printed on the bottle looks worse. A patient whose coinsurance is tied to the printed number may not touch the later check. The rationality is ugly and complete. The manager is paid, in part, for extracting the concession. The manufacturer is paying for share. The plan is buying a net. The member is standing in a different hour of the same transaction.
Formulary control is the enforcement arm. Prior authorization, step therapy, quantity limits, and tiered copays are not decorations. They are valves. Open a valve and a product flows. Close it and a rival product, or no product, takes the script. Clinicians argue medical nuance. Benefit managers argue evidence and cost. Both arguments can be true in the same week. The valve still moves share, and share is what the rebate buys. Spread pricing is a different scene. Here, the opacity is not a later manufacturer check. It is 2 invoices for 1 fill. The plan sees a charge. The pharmacy sees a payment. The difference, when the contract allows it, remains with the manager. Some public programs and some employers have moved toward pass-through pricing, in which the manager is paid a disclosed fee, and the reimbursement is meant to equal the amount billed. Other contracts still tolerate a gap. The Government Accountability Office, looking at state regulation rather than at a federal competition narrative, treats spread pricing as a real reimbursement arrangement states have tried to see and sometimes to cabin.
That is the cost control function and the conflict standing in the same statute book. A state hires or permits a manager to restrain Medicaid or employee plan spending, then writes a second law because the restraint itself became an unreadable price. Pharmacy networks tighten the vice. A narrow network can deliver deeper discounts because volume is promised to fewer stores. It can also push fills toward mail order and specialty pharmacies that share a parent with the manager. Steering need not arrive as a shouted command. It arrives as a copay that is lower inside the family, a refill protocol that defaults to 90-day mail, a specialty-only clause for a drug that used to sit in a refrigerator behind an independent counter. The independent store experiences this as extraction. The plan sponsor may experience the same design as a discount. Both experiences can be documented in the same week of claims. Vertical integration is the architecture that makes those experiences collide. When claims, insurance risk, and dispensing sit inside one enterprise, a dollar can change costume without leaving the building.
A rebate credited to the insured line, a margin earned at the mail warehouse, a medical premium that looks stable because the drug benefit was managed. The enterprise can be rational at every subsidiary and still leave outsiders unable to say what the medicine cost. Competitors without a clinic, a carrier, and a warehouse feel the asymmetry. So do patients, whose choice of pharmacy is a network artifact. Barriers break in sequence. First, the claims processor becomes a price designer. Then rebates make list price a theatrical number. Then mergers fold the designer into the insurer and the dispenser. Then states audit Medicaid spreads and discover they cannot reconstruct a fill from public data. Then federal staff publish concentration figures that make the market look less like a tournament and more like a corridor with 6 doors. Dominoes do not fall as a morality play. They fall as contract amendments. A manufacturer launches at a higher list and a richer concession. A plan renews because last year's net looked tolerable. A pharmacy closes a Tuesday. A specialty patient is told the only in-network shipper is the one with a sibling logo.
The wound the documents leave is not a neat verdict. The Government Accountability Office still describes a cost administration function that health plans have reason to buy. Someone has to adjudicate millions of claims, police fraud, assemble a national pharmacy file, and bargain with companies that do not volunteer discounts to the unorganized. The Federal Trade Commission staff still describe a concentrated, vertically tangled market in which the same functions can distort which pharmacies survive and which medicines are easy to start. Those 2 sentences can both be accurate. The staff report does not establish that every pharmacy benefit manager contract raises every patient's price. Anyone who turns the interim analysis into that sentence has left the evidence. Anyone who treats the concentration figures as a rounding error has also left the evidence. The climax is the coexistence. A tool hired to control cost becomes, at national scale, a tool that allocates cost. The allocation is legal, contractual, and, in the qualified language of the investigators, capable of harm. The chain does not snap, it thickens. Patients still pick up bottles, plans still sign. Manufacturers still ship. Pharmacies still transmit claims at 2 in the morning. Somewhere in that ordinary traffic, a rebate posts, a spread clears, a related pharmacy wins a fill, and the list price on the label remains a number almost nobody in the chain treats as real.
Strange markets do not always hide a crime. Sometimes they hide a job description that grew a second job. An intermediary is supposed to make a thick market thinner. Fewer negotiations, cleaner claims, a price that can be compared. In the United States drug benefit, the intermediary became the market. That is a specific economic shape, not a sermon about power in general. When the fee for standing in the middle can rise with the gaps in the middle, the gaps become inventory. Rebates indexed to list, spreads between 2 invoices, and fills retained inside a corporate family are not mystical. They are ways a rational firm harvests the distance between a manufacturer's posted number and a patient's closed fist. Health plans keep buying the service because running a drug benefit without aggregation is a different kind of expensive. A mid-sized employer cannot credibly threaten a diabetes franchise. A state Medicaid agency can try, then discover it still needs someone to turn millions of national drug codes into payable claims before Friday. The cost control function is not a public relations sticker pasted on a predator. It is a real demand.
The conflict is that the same demand, once concentrated and integrated, can decide which molecule is convenient and which store is viable without ever announcing a philosophy. Customers feel it as a copay that ignores a later concession. Workers in small pharmacies feel it as a reimbursement that arrives below what the wholesaler charged. Suppliers feel it as a formulary cliff. Competitors without a carrier and a warehouse feel it as a door that does not open the same width. And industry feels it as a handful of contracts that set the weather. The aftertaste is an invoice that never quite belongs to one party. Look at a single tablet long enough, and it dissolves into ledgers. Acquisition, usual and customary, guaranteed maximum, rebate receivable, member cost share, spread, pass-through fee, specialty margin. Each ledger is defensible to the person who owns it. Together, they produce a price that is less a fact than a truce. The truce holds because no participant can walk away from the corridor and still reach the patient at national scale.
Imagine, hypothetically, a future year in which every concession, every pharmacy payment, and every plan charge for a fill had to appear on one public line. Do not invent the crowd that cheers. Do not invent the helicopters. Just notice what the thought does to the current machine. Some concessions would shrink because they could no longer be paid for with someone else's opacity. Some plans would pay more in visible fees for work they now buy as a tangle. Some pharmacies would remain, some would not. The tablet would still be a tablet. The haunting question is not whether America needs someone to bargain over prescriptions. It is this:
If the firm hired to lower the bill can be paid from the shadows on the bill, whose cost is actually being controlled?